Hello, everyone. Hello, everyone. We are going to talk about the diabetes medications today, diabetes drugs. It's a big presentation. You guys probably already noticed, so we'll be doing it in probably 2 parts. So please make sure you listen to part 1 and part 2 of this. So let's just get right into it. A lot of this initially is going to be pathophysiology review, so it will be FYI for my test and not you won't be responsible for exam purposes for me. Just a couple definitions, just real quick, make sure everyone's on the same page. Type 1 versus type 2 diabetes. Big difference here is that with type 1, it is an absolute insulin deficiency. There is no endogenous insulin, so they are completely dependent. Those people are completely dependent on exogenous insulin, which we'll talk about those preparations and those insulin formulations here in a little bit. And then type 2, it's a relative insulin deficiency, so they may or may not have to take exogenous insulin. Here's some characteristics of type 1 versus type 2. Just go ahead and read through that. But again, just FYI for my course, you don't have to memorize this. Historically, or you may still hear some family or friends, lay public, talk about adult onset versus, younger onset, or, childhood diabetes versus adult diabetes. That's not preferred anymore. So please stick to using type 1 and type 2 with your patient population in the healthcare setting, because nowadays it's not exclusively type 1 can happen in a younger population. It says here usually greater than 40, so usually and historically it was more for older adults, but now it can happen with younger adults and adolescents and children, unfortunately. So stay away from that as far as to saying adult onset versus just stick to type 1 and type 2. And that's again just FYI for my course. This again is just FYI, but just interesting that there can be some secondary causes of, so a person can be born with this disease, diabetes mellitus, or it can happen because of some drugs they take, for example, an infection, etc. So just go ahead and read through that, FYI. And then sometimes too, when women are pregnant, they have what's called gestational diabetes, so to speak, secondary to pregnancy, which we'll be covering a lot more in pathophysiology and your ICM courses. So again, just FYI for me. Same thing here, FYI for my course, don't stress about that. This one as well, just an overview. You'll see this in pathophysiology. You definitely study for it for that course, but for mine, just FYI. Same thing here, not going to pull any test questions from that. This as well, just review, go ahead and read through that. Same thing here. Also here, FYI, just put a FYI on a lot of these slides here. It's good stuff though, and maybe it'll help you guys. Some students have said that it does help them with pathophysiology. This one also too, this may also help later on. We talk about some of the mechanisms of actions for you more visual learners. Some of these may help you kind of visualize what's going on. And then specifically too, when we talk about insulin, this may help you kind of visualize what is going on with the insulin. But you'll notice there's some drug names here, some of the sulfonylureas, for example, we'll talk about in a little bit. So anyway, so yeah, this may help with studying for mechanism of action. Complications of diabetes, again, FYI from my course, but just basically chronic hyperglycemia is a bad thing, causes a lot of different problems, both in the microvascular and the macrovascular. So you'll notice here it's listed here. So again, not for testing purposes for my course, don't stress about it too much. DKA, diabetic ketoacidosis, same thing. Won't see test questions for my course, but just FYI there. Same thing here with this slide, just FYI. May help be beneficial with pathophysiology. All right, so now here we go. Put a big star here. No, you don't have to put a star on the slide, but we are going to be talking about these medications, definitely heavy for testing purposes, etc. So please study all of these. Also, too, a quick note here. We're going to go ahead and cross out this category later on, and we're going to add a few more categories that aren't in this box. But just so please know that you are going to be responsible for all the categories I talk about today, and so there will be a few categories that are not on this slide. So just heads up on that. First and foremost, we have a big player for both type 1 and type 2, nowadays more so type 2, insulin. So we have the different preparations as far as if they come in combination or not. But I definitely want you guys to know, for testing purposes, make sure you know which ones are rapid acting, which ones are short acting, which ones are intermediate acting, and which ones are long acting. So for testing purposes, you will need to know the difference. Guaranteed, spoiler alert, there will be test questions that say, hey, which of the following is a long-acting insulin? And you'll have to be able to pick that from there. So please make sure you know the difference between the different types of insulin, and make sure when you're studying them, you categorize them as being, and it's, again, I don't try to make you guys just memorize and study things that are arbitrary. This will come into play with when you are prescribing, and when you're trying to get your patient to use insulin, it's going to be important, and hopefully that'll be fully elucidated throughout this presentation. But so it's not an arbitrary thing. There is some method behind my madness, but please memorize those and make sure you know how they are categorized. Like I said too, they have to be used in all type 1 diabetes patients, and because they do not have any endogenous insulin, you have to administer exogenous insulin. And then it says about a third of type 2, so it's going to depend on, don't necessarily worry about memorizing that, but just know it's not as common with type 2. However, it's going to depend on what part of the country you end up practicing in. What's your patient population? Are you working with a lot of type 2 diabetics? Are you not? Are they old? Are they young? Etc. So the insulin, you may have, the majority of your type 2 diabetic patients that are on insulin. So don't necessarily worry or get hung up on the third of a patient. This is just kind of, an older stat there. But anyways, but definitely type 1, always think about insulin and an exogenous insulin, because they will need that. And then 2, it can be used for pregnant women who have the gestational diabetes. Historically, they were animal-based, so with pork and beef, pancreas products, but nowadays you don't have to worry about those anymore, because there were some allergies people had with that, or some cultural or religious reasons why they couldn't take those, depending on their background there. But now they use recombinant DNA technology, and these are a lot better products. They're more consistent, they're more predictable, they have better kind of profiles as far as how they're absorbed and what effect they have. So overall, historically the animal-based products were more erratic as far as absorption and the effect and everything. So it was kind of a pain for patients. And then the allergic reactions, definitely that was it's advantageous now that there are not as many allergic reactions, because if they're not animal based. So a lot of these points are already talked about, but yeah, just basically it's, these new preparations, just long story short, are a lot better than their historical counterparts. Concentrations of insulin, just kind of FYI, but this will be important when you're writing your prescriptions. They are in units per milliliter, so it's here's the formal definition, which you don't need to worry about. But then they come in a couple different preparations: 100 units per ml, 500 units per ml. So this is just kind of FYI, but it is in units. So most of your medications will be in milligrams, maybe some micrograms, milliliters, but with insulin it will be units. With that note, just please, it is considered bad practice to abbreviate the units with a U. And the reason is because you'll notice here, so like you wrote 100 units, or you wrote 100 U, the U can unfortunately sometimes be mistaken for another zero. So instead of, 10 units, you end up, the patient ends up getting 100 units, which can be very detrimental to the patient. Some bad adverse effects, which we'll talk about in here a little bit. But so unfortunately, there's been a lot of medication errors with that. So please just, best practices, when you are ordering anything with units, specifically insulin, please write out units. So if you want 10 units, the good news is that it's fastly kind of becoming an older issue, just because a lot of electronic health records, a lot of things are typed out now. So when you go in your hospital or in your rotations and you put in an order for insulin, it automatically writes units in there. But I mean, you can still, outpatient setting, you can still write. There are electronic prescriptions, but some people still handwrite prescriptions. So anyways, depending on where you end up practicing, just FYI on that. It is a subcutaneous injection. They do have pumps, continuous sub-U pumps. That is, you'll see those typically for type 1 diabetic patients. They also have an inhalation preparation so they had one on the market. It was withdrawn. It wasn't popular. Then they came out with a new one called Afrezza, this is a brand name. So I normally don't have, you guys memorize brand names, but the generic is just inhaled insulin. So I put the brand name there just because I think it'll be easier to hopefully to remember. This can be used for type 1 or type 2. It's typically reserved for type 1. So ADA, American Diabetes Association from 2017, it doesn't recommend it for type 2 diabetics in general. And really it's like with the previous product that was withdrawn, they're not very popular. They haven't really taken off. I think when they first came out, this was before the initial product was withdrawn. And by the way, the Afrezza came out in 2014. But I think they were like, oh, everyone hates injections, everyone hates, having to inject themselves in the subQ. So this is going to be, the best thing since sliced bread or whatever the saying is. And it just never really took off, and there were some issues and people didn't like it and whatever. So, and then ADA now just recommends it just for type 1. But it's even then like not first line, and then type 2 rarely. So anyways, I put this in there just for a complete picture, but as far as you're prescribing it, etc., probably not going to be prescribing a lot. The other thing too, you have to be very careful with is if anyone has asthma or COPD, there's a box warning there. Definitely read through that. There is an increased risk of acute bronchospasms in patients with asthma, COPD. So, and it is contraindicated, etc. So that is something that if you ever come across an instance where you do want to prescribe it for a type 1 or that rare type 2 patient, definitely make sure that they do not have asthma, COPD. They don't have any, make sure they don't have any lung disease or anything like that. And another thing too, just FYI, because I've had students in the past ask me, what the heck, how does that work? What is inhaled insulin? It sounds, crazy or whatever. Just FYI on here, don't worry, stress about memorizing this. It's just more for your information. You'll notice that if that rare instance where you are going to prescribe it, that you will have to do an adjustment as far as what injected insulin dose were they on here, and then the Afrezza dose. Then it comes in 4, 8, and 12 units, and you have to kind of mix and match to get the proper dose. And but anyways, and this is what it looks like when it's ready to be inhaled. But you don't have to memorize any of this for testing purposes or anything. Just make sure that you note that there is an inhalation product available when you're studying, but the vast majority are going to be subcutaneous. And then I won't go into the specifics as far as the pumps and the different products and everything for testing purposes. Just know that they exist and they're out there. Most rapid form of absorption is going to be the abdominal injection. You can also use some of the other sites, which I have a visual coming up here to show you those sites of where you can. You do need to make sure you tell your patients to rotate the injection sites in the abdomen, because they can cause a fat to be redistributed in a bad way. So basically, you end up with this going on. So this is what happens if you inject insulin at the same spot over and over again. The other thing too is it can affect the rate of absorption, so it's good to rotate the sites. And then here's some injection sites that you can be rotated. But again, preferred and kind of the go-to is going to be lower abdomen, and then of course rotated specifically where they are injecting it. And it says the same thing here. Injection sites should be rotated. So anyways, and it is going to have a better absorption in the abdomen than the arms and leg. Rapid acting insulin. So again, please make sure you know which ones are categorized as a rapid acting. One thing I didn't note earlier is that, and I believe I have a table here, that the naming or the categorization is based on how the onset of action, duration of action, and the peak effect. So you'll notice the rapid acting, for example, has a quicker onset of action rather, so it's 0 to 15 minutes, so it works right away, versus shorter acting is slower onset of action, intermediate is a little bit longer, and then the long acting is going to be the longest there. Also, the duration of action is, so the long acting insulin has the longest action, so it has like 24 plus hours, so about a day, and going down the line, less duration of action when you get to the faster acting insulins. And then peak effect too is important to be thinking about with these different preparations. You'll notice the rapid acting has the biggest peak versus the long acting has no peak. So keep that in mind when we're talking about these. This one is going to be, the rapid acting is going to be good for a postprandial administration. So that means, postprandial means after you've eaten. And you'll learn in pathophysiology. So when you eat, your body normally releases a bolus or kind of, a spike in insulin. And so this rapid acting is supposed to kind of mimic that. So you eat a big meal, your body, a person without diabetes, type 1 diabetes, for example, will release a bolus amount of insulin. And then it'll peak and then drop off. The other thing too that happens in a normal person, which we'll talk about this more when we get to the long-acting insulin, is that there's also a background basal insulin that is in our bodies at all times. So you can think of that as a flat line on a graph where, if a person does not have type 1 diabetes, they just always have that background, what they call a basal insulin dose, and then you have these bursts of insulin that are released when you eat a big meal. So this postprandial administration of rapid acting insulin is supposed to mimic that, insulin that would have been released by your body if you did not have type 1 diabetes. So hopefully that makes sense. It is more rapid absorption. We talked about that. The idea is that you do give this before meals. So this will usually 3 times a day before meals, or if it's going to be a big snack or whatever. It's really going to depend on the patient and how they eat. But so this is pre-meal administration. So 3 to 4 times is usually what we see being filled in the pharmacy with these rapid acting insulins. And then like I touched upon a little bit, but it can be, or ideally will be used in conjunction with a long acting insulin. So we'll have the insulin, glargine here. So insulin glargine is an example of a long-acting insulin with the Lispro, let's say. And so the prescription would go, or kind of the ideal situation would be that you give a once-a-day dosing of the insulin glargine, and then that'll give that background kind of basal level of insulin throughout the day, kind of a lower level. And then will prescribe the rapid-acting pre-meals to help with that postprandial spike in glucose. So hopefully that makes sense, and definitely please remember that for testing purposes. Ideal insulin administration is going to be that, and by the way, there's going to be additional presentations on administering insulin, or rather dosing insulin and kind of how to do it. So if you missed it a little bit, maybe, listen to that other lecture too, and then see if it maybe clicks after you hear the second lecture that's specifically on the dosing of insulin. But anyway, so yeah, just a quick overview. So kind of ideal insulin administration for a patient is going to be a long-acting one to give that basal background, plus a rapid-acting, or maybe short-acting to regular insulin. That's going to be pre-meals and to help with the postprandial glucose spike. Or short-acting insulin, pretty easy for studying purposes. We just have regular insulin to work on. So slower onset relative to the rapid insulin, and also longer duration of action. That's why I like this. I like this table. And there's different tables out there too in different textbooks, and UpToDate has one a little bit different. But basically, they all have onset of action, duration of action, and peak effect. But I feel like this will help you guys when you're studying and kind of keep them separate in your mind and thinking about them. But so anyways, this is all what this is just saying. This is going to be your drug of choice, or insulin of choice, rather, if a person has DKA. So you'll be seeing this given IV in a hospital situation. This one is less ideal for the postprandial glycemia. Like I said, the rapid acting is going to be the first line for if you're trying to hit that postprandial. It could be used the regular insulin, but again, it's not going to be first line and ideal for that. So it can actually cause the because it has let's go back here, because it has a longer duration of action, it's 5 to 7 hours. The onset of action is longer, or is more delayed as well. Then you can actually end up getting postprandial hyperglycemia, and then it causes because it's not timed properly for the meal. So you eat the meal, you get hyperglycemia, and then the insulin kicks in too late. So then, and it kind of is sort of an overshot, then it actually causes hypoglycemia. So when the patient goes in hypoglycemia, then you can have it can cause snacking, weight gain, and elevation of the hemoglobin A1C. So that's where the rapid acting is going to be preferred to be given before meals. And then so the regular insulin is going to be better, usually hospital setting, and like I said, for diabetic ketoacidosis, or sometimes they also have what is called a sliding scale insulin dosing, and this is going to be done again inpatient setting, so in a hospital setting, but it's just basically the nurses will take blood glucose readings and then throughout the day and kind of regardless maybe, or they have them scheduled and it depends on meals and stuff. But basically the sliding scale just refers to they'll have some type of insulin on the sliding scale protocol, and then it's basically they get dosed based on what their glucose is. So basically, quick Google image search, and you can get an idea of some of these, and the hospitals will have these. But basically, this first one here, so it depends on the blood glucose of the patient, and then they'll have different units then of what they give. So most patients here will fall here. So blood glucose in 200, then they get 4 units of short or rapid acting insulin. And it's going to kind of, as far as the specific insulin they're going to be using, it's going to depend on the hospital and the facility or whatever. So this is a visualization of what I was saying and what is you might be seeing in your hospital rotations. And this is besides repeated, but again, I think it's good for studying purposes. You're going to see it a few different times, but it helps. I think it'll help you guys keep them straight. We also have NPH, which is an intermediate. It's the only one you have to worry about first for this category as well. Usually called NPH, or I'm sorry, NPH stands for neutral protamine Hagedorn. Usually, I've never heard anyone say that. They all just say NPH. So just for testing purposes, just NPH is all you have to worry about. It's the only one, like I mentioned. It's an odd duck because it's in between. It's not really quick and it's not really short. I guess that's why it's called intermediate, right? But it has erratic absorption, variability amongst patients, so it's typically not first line. It's one of those, it's still prescribed and it's around, and they make some combinations with it. I think mainly because it's cheap, and so, you don't have to worry about it where the patient can't afford it or whatever. So you will still be seeing it used for type 2 diabetes, but again, usually not first line with insulin. It's not something you will really just want to just jump off and start with. And there we have it there as far as onset of action, etc. Oh, that's another thing too. I was going to say, I've had students ask me if I want them to memorize these specific minutes and hours. You do not need to memorize that. So for example, I won't have any questions that say, what's the duration of action of a short acting insulin? And I want you guys to memorize 5 to 7 hours or memorize, peak effect. However, I do want you to know, like I said before, which ones fall in which category. So which ones are considered rapid acting, which ones are short acting, which ones are intermediate, and which ones are long acting. And then have a general idea of what that means, and kind of how they relate to each other. And that's what I was saying, this table I think is important for studying purposes. And I'd put a star on here for studying purposes, just really because I want you guys to know how they're categorized, and then what does it mean that something's rapid acting? So I want you guys to know what it means, but not necessarily then say, memorize the onset of action is 0 to 15 minutes. So I don't think that's important for memorization. Last, we have the long acting insulins. We have 3 here that you'll need to memorize and make sure you categorize properly. And like I said, this will give that basal background insulin that'll have you, throughout the day, 24 hours plus, delayed. These are all delayed release, so they're formulated in a special way to have 24-hour release, and so you don't have to worry about a peak effect. So typically it's once a day. Sometimes it's twice a day, depending on the patient and depending on the specifics. By the way, QHS just means at bedtime. That's the abbreviation. You guys haven't had the abbreviations for prescription writing, but QHS just means at bedtime, or BID, which is twice a day, so usually morning and night. Then these should usually be used in combination with a rapid acting that is given at meal times. And so this is going to be good for both type 1 and type 2. And like I said, it's going to be this long acting is part of that strategy of a good insulin administration. We also have the insulin detemir, same thing, once or twice a day administrations, 24 hours, consistent duration, they're good for that basal insulin. And last but not least, we have the insulin degludec. This is the longest acting, but a little bit more than 25 hours independence of dose. This one is only once a day dosing versus the other ones can be once a day or twice a day, and that is because it is longer acting. I've had students in the past ask me, so, this is the one you prescribe? Not necessarily. I mean, I would consider all three to be, they're not exactly interchangeable. Well, I take it back. So these first two, the insulin glargine and then the insulin detemir, you can interchange. And so depending on your hospital formulary, they will be interchangeable. And so, if a person comes from home and they're on one, you can just start them on the other. This last one, the degludec, it's a little bit different, but for categorization purposes, go ahead and put them in the same category. Just know that this one, the degludec, is longer half-life. So it is at 24 hours, 24 plus 25 hours, right? And it will just be the once a day dosing. And this is just a visual representation. It kind of was what I was talking about as far as that, this is a long-acting insulin. It has the plasma glucose. It's a more steady sort of line on the graph. Versus the other insulins they have the different peak effect. So, this is just illustrating the peak effect of the different insulins. Mixed insulins. So again, you don't have to memorize these. Just know that they do make combinations of insulins that may be advantageous for some of your patients. I'm hesitating a little bit because typically when a patient first starts on insulin, you don't want to just jump on a combination. You want to kind of figure out what works best for them before. And then here, and actually this is not just, I'm just making this up, it's from the ADA guidelines. It's never recommended for type 1 diabetics because they need a tighter control, so they need better control. And with the mixed insulins, you don't always get the best control. So almost never type 1, and then rarely they're going to be used for type 2. And then here are the specific guidelines of when they can be used for type 2 or when you can, mix insulins. And just also so you know, they make combinations. There's commercially available, and then patients can mix insulins themselves. But just be careful when mixing insulins because some products can't be mixed with others, etc. So I'm not going to go into the details with that, you guys. I don't feel like you need to memorize that for testing purposes. But just know that just be cautious when you are mixing insulins if you are not doing a commercially pre-mixed version. And then also to definitely stick to the ADA guidelines, American Diabetes Association guidelines, as far as when you are recommending and prescribing mixed insulin. So please go ahead and read through this slide. Uses, we've talked about these already, but definitely type 1, it's going to be all type 1s. DKA, definitely using the regular insulin for that. And then type 2 diabetes. And this is not going to be first line for type 2 diabetics. This is going to be when their lifestyle modifications and then when their oral medications have failed. Then you're going to go to insulin, which, again, like I said, depending on where you practice, which population, which part of the country, etc., it's just going to kind of depend if you're going to have to start insulin sooner than later. So it was one of those things that, out of pharmacy school on rotations and then out in practice, you kind of start, you kind of start seeing like, I know they said that, don't start the type 2 diabetic right away on insulin, but, but then there's that patient who's, in their 50s and, or, mid 40s, early 50s, and they've never seen a doctor, and it turns out they're in pretty bad shape. And so anyways, they maybe have to start on insulin a little bit sooner than others. But, if you can, definitely diet, lifestyle modifications, and then the oral medications, are going to be first and second line, which we will talk about more in detail in a separate presentation. So stay tuned for that. Adverse effects, definitely put a star on this slide. I want you guys to make sure you know the adverse effects for insulin. Specifically, put a big star here with hypoglycemia. So it makes sense if you think about it, what insulin does, and you're giving insulin, but it can be fatal. It can cause hospitalizations and can cause some really severe problems. So it's a very serious, and unfortunately it's a common adverse effects. So definitely, and you'll notice this with all these anti-diabetic drugs, we're going to talk about hypoglycemia as an adverse effect. So it's kind of like with the anticoagulants, we talked about how bleeding is an adverse effect kind of globally for all of them. So definitely adverse effects for all the anti-diabetics, but then specifically for insulin, please remember the hypoglycemia is an issue. And that's part of the reason why too, it's considered such a dangerous medication. I know when I was in pharmacy school, I was like, what, insulin's dangerous? But because it just seems, I don't know, it just seems so innocent there, just so peaceful, and it's glassified. I don't know. No, but it's a very, all joking aside, it is a very dangerous medication. And one of the issues is because of the dosing. Like I said, the 10 units versus 100 units, there are some dosing medication errors and stuff is part of it. And then unfortunately too, the hypoglycemia can be an issue. So make sure you look at the signs and symptoms of that. I won't read through those. Same thing too with the autonomic hyperactivity. Make sure you read through those as well. And the good thing is that the hypoglycemia can be rapidly relieved by giving glucose. And so they have oral glucose, but they also have IV. So D50W is going to be maybe prescribed. And then they make a glucagon, which we'll talk about more in detail in a little bit. But anyways, and so those can be relieved. Or rather, the hypoglycemia can be relieved. Okay, and I fixed the slide here on mine. It'll be fixed in the PDFs I provide you guys, but I felt like this was kind of a little weird as far as reading. So the signs of severe hypoglycemia or insulin overdose include all of these below. So make sure you look at those and you're familiar with those for testing purposes. We also have the changes in subcutaneous fat, the site rejection, the lipodystrophy, which I talked about. And that one is a pretty easy adverse effect in this fact that it can be mitigated by rotating the injection site. So that's a reason to do that, to make sure you educate your patients on rotating the injection sites. And now we're going to get into, next is going to be the oral medications. So these, and the other anti-diabetic agents, there's some other ones that aren't necessarily oral, but let's go ahead and stop here. I think this is a good stopping point. So as always, please email me if you have any questions, comments, or feedback, and let me know if anything was confusing or whatever. Other than that, I'll talk to you guys later. Make sure you listen to part 2.